DB-11, DB-05. What are you going to use T-DXd? Are you going to use it neoadjuvantly, or are you going to wait and use it adjuvantly?
So we are here to address the tough questions and to provide our 2 cents, our opinions.
100%.
Because I think there is the data, but then you need to produce, a treatment recommendation based on those.
Yeah.
I prefer neoadjuvant because it's a shorter course, because it's effective, because if you get the patient to PCR, you don't need any more cytotoxic treatment. So I prefer neoadjuvant for 4 cycles. And then if the patient has residual disease after neoadjuvant T-DXd, our friend Jason is going to tell us how we treat these patients in the adjuvant setting.
Yeah, so they call us the best friend for a reason. I agree with you. I would rather give it to them because then you're in charge of the situation in the neoadjuvant setting. So your patient, if they qualify for the DXd, you can give it to them. A lot of time when we go to the adjuvant setting, our patient might not be the perfect candidate anymore to receive it, and they might not get it, and they might not get a very important therapy that they need in their journey. Now, if they received it early on, what's going to happen in the adjuvant setting is a little bit more complex at this point. And it takes, again, the art of oncology to come. They say AI can replace doctors, that it cannot. It cannot for that reason, because there is a lot of data gaps out there that you need to use your own judgment as an oncologist treating the patient in front of you to see what you're going to do adjuvantly. We have a lot of options, thankfully. So thankfully, we have a lot of options. T-DM1 is still a good option. T-DXd, you can do it. We don't have data using T-DXd after if you use it before, but it's going to be an option. Also, you can use HP, and there is a very important drug that I like, very underutilized in the US, neratinib. Neratinib is a fantastic drug. It reduces the chance of CNS recurrence. It also reduces extracranial disease. Very important drug. But I think this field is going to play out. But what's really reassuring, you talked to me one time about a poster that you saw, I believe, at ESMO, about using T-DM1 after T-DXd. And it showed activity of that agent after T-DXd, which is something that's very interesting and very optimistic for me. What can you tell us about this?
Absolutely. I was lucky enough to be at ESMO Breast presenting a poster, and in front of me there was exactly the poster of what happened with T-DM1 given after T-DXd in Destiny Breast 03. So a large prospective trial. There were about 60 patients that received T-DM1 after the T-DXd, and what they saw is that T-DM1 had the same activity that after T-DXd than it had prior to T-DXd, about 7 up to 8 months of duration of treatment, which I think in the metastatic setting is promising, but this tells us that when you switch the payload, actually you can retain activity 100%. With ADCs. And so I do think for patients that receive T-DXd prior in the neoadjuvant setting, considering T-DM1 in the adjuvant setting, it's totally reasonable because it has a different payload.